very warm good evening from New Delhi to all of you to this first episode of Maitri PregaClinics. This is an initiative that we had thought about for a very long time. We had a great inaugural with the IDF President-elect, Dr. Neeti, being our chief guest, and Dr. Banshi Sabu, our guest of honor, along with a lot of our stalwarts, Dr. Anuj, Dr. Sunil Gupta, Dr. Pratap, I think everyone who has a stake in pregnancy, everyone who manages pregnancy has been part of this initiative, a very novel initiative that we've taken for the first time, because we always talk about managing patients with diabetes and diabetes in pregnancy. Hyperglycemia is pregnancy is a very important part and parcel of diabetes care for our patients. Gestational diabetes is something that happens in pregnancy, but then there is a very important component of why preconception care today is important, not only to prevent gestational diabetes, but eventually if it occurs, how to manage it and to prevent conversion to prediabetes and diabetes later on. And then hyperglycemia in pregnancy also includes pre-gestational diabetes, which is pre-existing type 1 or type 2 diabetes in pregnancy. How do we manage that? That is again a very different issue. And then, of course, there are certain cases where now we are seeing a surge in diabetes being detected in the first trimester itself, a term that is being coined as early gestational diabetes. So PregaClinics is basically a concept visualized by Dr. Rajiv Chawla and me. That is why we thought we the sutradhars for this program. And our knowledge partners for this are DIPSI, AOGD, as well as PSG India. This is an initiative where instead of doing regular lectures, which sometimes are not, which absolutely are one person delivering a monologue and everyone listening, we thought it's time we take it to the next level where we have active real world case discussions. And learning through case discussions is something which gives a very interactive and a very real world aspect. So a real case who's come to you in the OPD, how you've managed that, and we have experts to guide us today on exactly what should be done, how it should be done, and why it should be done. So I welcome our experts, Dr. Pratap Jethwani and Dr. Rutul Goklani, two well-known figures in the field of diabetes as well as diabetes in pregnancy, as well as our mentor, Dr. Rajiv Chawla, who we all know is again, who obviously does not need an introduction. Past President DIPSI, past President RSSDI, Editor-in-Chief, IJDDC. Dr. Pratap is a national EC member and he's held various positions and a very, very prominent national figure when it comes to diabetes and pregnancy management. And Dr. Rutul, who also gave birth to PSG, the Pregnancy Study Group India. Somebody again who's very actively involved in pregnancy management, diabetes management, especially in Gujarat, taking it to the country as well as abroad. And of course, our speaker, none other than Dr. Nimmi Mulvani, a diabetologist who finds women's health as her passion. And she's just started another forum for all female doctors getting together, a metabolic what's the name of your forum, Nimmi?
Metabolic Alliance.
Metabolic Alliance. An alliance again wherein we have discussions on different aspects of metabolic diseases, especially in women. So our speaker today, Nimmi, is going to present a real world case of early GDM, presenting to her in the clinic, and she'll take us through the management of this case, and we'll have expert advice, expert pearls from all our experts present today. To take the session forward, our moderator today is Dr. Ninad Gaur, diabetologist and metabolic physician from the city of Bhuj. Again, a very young, upcoming, bright diabetologist, very active into academics. So welcome, Dr. Ninad, and I hand over the proceedings to you.
Thank you so much, ma'am. Thank you for your kind introduction. The forum is lit up with great personalities who have dived, we can say in Hindi, in Gujarati we say कि गोल के पी गए हैं पूरा pregnancy in diabetes को. Having such experts, such mentors in this forum, it definitely is going to have precision care for each and every patient coming to our clinic. So we'll enhance our knowledge with this. So moving forward, let us hand over the dais to Dr. Nimmi Mulvani, ma'am. She is going to present a case on early GDM which was presented to her at 14 weeks, which is really concerning for us, as Dr. V. Mohan sir just previously said a few days back, that we need to screen every female coming into our clinic while she is pregnant, because we don't know when the GDM is going to come up. 1 in every 3 females is going to get GDM, and we don't know which one at what time. And with this one coming up at 14 weeks, it really rings a bell in our mind. Like it's a siren that we need to work on, and we need to keep it in our mind that yes, every pregnant female is a potential GDM patient. So we should screen them at an early age, at an early time frame, so that we can have it early on. So giving over the dais to Nimmi ma'am.
Thank you. I thank Dr. Shalini ma'am, Dr. Rajiv sir, Ritul bhai for giving me the platform to present the very first case in PregaClinics. And with this, I'll share my screen. Visible? So
Yes.
when we,
Go ahead.
Thank you. So when we talk about GDM, our first thought goes to obese patient. Our thoughts goes to patient who had previous history of PCOS, someone who is not healthy in terms of obese patient. But this is a unique case. This was Mr. Shivangi Ketan Shah, 29-year-old primigravida. Her BMI was 22.7. She had no family history of diabetes, no significant previous medical history. She was physically active and she had accidental conception of pregnancy after being married for 2 years. RBS at first antenatal visit at fifth week in gynecs clinic was 104 in glucometer. Gynecologist did not advise anything further. At the second visit at 12 weeks, the RBS was 124. At this point, she being my friend, she referred to her at our clinic in Ahmedabad, where we checked her RBS and glucometer, where it was 118 in the evening. And we advised her to do 75 grams of OGTT next day morning. But patient already had promised relatives and she had to go to her native place, to her mother's place. And she returned after 2 weeks at 14 weeks. At 14 weeks, she did OGTT and came to me with the result. The fasting was 108. 2-hour OGTT was 168. This was after 2 hours of 75 grams of oral glucose. HbA1c was 5.7. I added HbA1c with OGTT as well. Diagnosis I detected as early GDM or possibly undiagnosed pre-diabetes in this primigravida. So at the 14th week only, when we saw that sugars are above the normal required range for a diabetic and pregnant patient, we advised her to start on basal-bolus insulin, at least one at a time. But patient and her family members, mother-in-law, were unwilling. So we started the patient on tablet metformin 500 gram twice a day with medical nutrition therapy for 1 week. The SMBG was done 4 times a day. Fasting was 100 to 114 in between the range. And okay, with occasional spikes going up to 120 plus. Postprandial breakfast 2 hours was 140 to 160. Postprandial lunch 2 hours was again 136 to 150 in average. And postprandial dinner was 138 to 150 in average. Patient was counseled on 15th week on SMBG readings only to start injection Tresiba. I started her on 10 units at bedtime, along with she was tolerating metformin 500 milligram twice a day well with no side effects of GI disturbances. So I decided to increase the dose to 500 milligram 3 times a day. And I instructed her that you should check SMBG every day and the dose should be up titrated plus 2 units if the fasting stays above 95. The patient was reluctant to check every day for 4 times, so she was checking every alternate or third day. This was the average SMBG chart and insulin titration chart. From the third day itself, the fasting started coming under 120, but still above 95, which was the target for her. So I increased the dose to 14 unit. Subsequently, this is the average of every week sugar that she used to do twice in a week. So I gradually increased the dose of her Tresiba from 14 to 16.
May I interrupt? May I interrupt?
Yes, sir.
Nimmi?
Yes, sir.
Okay. So can we go back to the first slide?
Yes,
Yes,
we
sir.
should start from the first one. So many
Yes, sir.
discussion points.
Yes, sir. Yes, sir.
So this lady was having a fasting of 108, 2-hour, OGTT 168, HbA1c 5.7.
Yes.
Now, is one abnormal reading on one OGTT, either one or two abnormal reading on one OGTT, this suffice to say that the patient is having GDM, or we need to repeat it? And once the second reading comes abnormal, then and then we can say that this is GDM. So what do the guidelines say? I think it is too abnormal. At least you have to repeat it, or you have to subject.
Dr. Pratap, this is a proper glucose tolerance test, 75 grams. This is not a random glucose.
No, 75-gram oral glucose tolerance test. What DIPSI says, once you do 75-gram oral glucose tolerance test, suppose the patient's 2-hour value has come 150 on first visit. DIPSI don't recommend fasting, but you have done fasting. Good. Fasting is 90 and 2-hour is 150. Will you stamp it as GDM, or
Yes,
you will
yes,
repeat
very
it
much.
after 1 week?
Yes,
You will
of
repeat
course.
it after
All
1
the
week.
guidelines, let me talk about DIPSI. DIPSI also
Yes.
clearly says that a random, irrespective of fasting, if you've done a 75-gram glucose and your 2-hour value is more than 140, she is labeled as GDM. Even if you look at the IADPST, the ADA guidelines which endorse the IADPST, which is talking about the 75-gram oral glucose tolerance test. So a fasting which is crossing 92 or a 2-hour which is crossing 2-hour here is 168. Yeah. So 2-hour is still less than 183, but then the fasting is already beyond that. So any one in a 75-gram OGTT, any one value which has crossed the target, you diagnose as GDM.
So that is first thing. So you
Yes.
diagnose it as GDM. Now, will you give
Pratap,
a trial of? Will you give
Dr.
a trial
Rajiv,
of
sir.
MNT?
Pratap,
Yes, sir. Yes.
when
Yes,
it
sir.
comes to DIPSI, we say that DIPSI's 75-gram glucose or oral GTT is diagnostic, and even if there is one value 2 hours more than 140, it is diagnostic of GDM.
Yeah,
Irrespective, because
GDM.
in DIPSI we don't talk of fasting sugar. In fact, we don't recommend as such, although she has done a fasting sugar also. So even
Yes,
if
yes,
fasting
yes.
was not available in this patient, fasting is already high. Even if it was not done, and post 2 hours after 75-gram glucose was more than 140, even if it is 142, it is diagnostic of GDM. So
GDM.
she has already done
I
HbA1c 5.7. That means there was no pre-existing or undiagnosed
pre-existing.
diabetes.
So this is early GDM. That is
So
okay. So will
I-
you straightway start with metformin, or will you wait for MNT? That is one thing.
In early pregnancy, we still have time, and we say that you may give a trial of 2 weeks with MNT. If it is a late pregnancy, then you wait only for 1 week. If it is early pregnancy, you can wait max of 2 weeks. And if after 2 weeks it does not settle down, definitely you need to start with either metformin or insulin. But
Here,
in her case, I think because fasting was high, which is exceedingly high, because we are talking of a
108.
cutoff of 90 actually,
Yes.
and 2 hours is clearly 168. It is not 145 or anything close to 140. So I think along with lifestyle modification, you are justified, because you don't want to give a very long time of hyperglycemia in early pregnancy. So she is justified in starting. She recommended insulin very rightly, although patient was reluctant. So she started with metformin initially twice daily, and then made it to 3 times a day. So I think that was a justified step, and because she was following every twice a week, although ideally we say it should be at least 4 times a day, one fasting and 2 hours after each meal. But even if she was not complying, patient was not complying every week, she found that fasting was more than 90. So good thing that she immediately started with Tresiba. But
So-
as she rightly said,
Can I-
in this case, we have 2-3 things which are very, very unique. One is that there is no obesity. One. Second, there is no family history or any history suggestive of PCOD in the past too. Third is that she rightly said, and Rutul also very correctly said, that we talk of early GDM today. If you go by Caucasian or IDPSG criteria or Western guideline, we say it normally will not happen till 24 to 26 weeks. She's at 13 or 12 weeks. At first visit also, her sugar was already on the higher side. So she's a typical Indian phenotype. Those who present with the GDM, even at 12 weeks, with a normal HbA1c. Although before you conceive,
Here,
ideally you
Her
should have
HbA1c is also
5.5.
again
her
even in
HbA1c is also, sir,
non-pregnant.
here
Yeah.
can I just come in once before this, before we progress further? Now, don't you see a missed opportunity here? Because the lady was told to come fasting for a GTT, she went to her village and she missed the test for 2 weeks. What if there a DIPSI test would have been done immediately in the OPD? Give
Yes.
her 75
Yes.
gram glucose, wait for 2 hours, check the glucose, you would have picked up dysglycemia earlier.
Earlier.
Here, because 2
Very
weeks,
true.
she just vanished. So this is again one reason, and this is a real world case. This is not something, So real world also, you can very clearly see in a city like Ahmedabad, when she's already coming to a diabetologist, just because she was advised a fasting oral glucose fasting, a GTT next day. Had a DIPSI test been done there, maybe we would have picked up this dysglycemia much earlier, because the BMI of the patient, no family history, so and the HbA1c is 5.7, which
It is
qualifies for
IGT
pre-diabetes.
outside pregnancy. Outside pregnancy
Yes.
itself, it is pre-diabetes.
Yes, so this
Yes,
5.7
yes.
was done at 14 weeks,
14.
maybe at 10, 12 weeks when she was referred. At that time, if a DIPSI test would have been done, probably we would have discovered more than 140 and we would have initiated MNT at that point.
Yes.
I
So
want
the
to
treatment gets
draw
delayed by
one.
2 weeks.
I want to draw to attention one more thing, and it is here. I can see is at 12 weeks, random blood sugar was 124. So it also says
Again,
something
yes.
that it is
Gross.
Yes.
gestational glucose intolerance somewhere.
Yes.
Again,
Yes.
And because it is between 120 to 140.
Yes.
So
Yes.
if we go for OGTT,
Yes.
definitely it may come higher than this.
Yes.
So this is also quite striking.
Yes.
Rutul,
So
And
there are so
Rutul,
many missed opportunities here.
yeah, Rutul, it is random. 120 is positive. This is for
Yes.
Yes,
mixed meal or something, not
exactly.
a GTT. So that
Yes.
itself is confirmatory.
Yes,
Yes.
yes, yes.
Yes.
So I
True.
think from this we can give 3 take-home messages. First is that if random is more than 120, or
Yes.
anytime if you are able to do 75 gram load glucose test, that is preferable. You can do HbA1c along with that, so that will give you a very good clue whether the patient is having uh, early GDM or a pre-existing diabetes or whatever it is. Second thing, one abnormal test one time is justified to give the diagnosis. There is no need to repeat. And
Yes.
third thing, in select cases, you can give medical nutrition therapy, but in such cases where you
Yes.
feel that medical nutrition therapy will not be enough, you may straightway start with metformin or insulin also.
And
That is what
Absolutely.
one
Dr.
point,
Nimmi.
sir, I want to add is that, yes, as our DIPSI guidelines and Ministry of Health and Family Welfare guidelines, what they say, that at each trimester, you should screen women. And this is the reason. This is the live case, real world case, and which is showing that we have good number of good ample amount of cases of early GDM nowadays, because as we can see here, the age of getting conceiving is getting higher and higher. So here you can see it is 29-year-old primigravida with lean insulin resistant diabetic case with no family history and no significant medical history of PCOS. So this is why we should screen each and every woman at first antenatal visit, at
Yes.
first trimester, second trimester, or third trimester, irrespective of any trimester. You should screen them every time.
Yes. Definitely, we say
Universal.
that the
Universal.
Yes,
the
universal
75 gram
screen.
oral glucose test is the gold standard, a fasting and then a 2-hour value, gold standard. If you are very sure patient is coming, then can do the test. Definitely no harm. Yeah, it's not wrong that you ask for a fasting and a 75 gram 2-hour value. But then in cases like this, real world cases, I think,
They
if the
have
patient
already missed
did
2
not do
weeks.
it and she went away and she came back after 2 weeks and then she did the test, so missed opportunity there again.
Yes.
Ideally,
Again,
at 5 weeks only, the first test should have been done. First point in
Sha-
pregnancy, first point of contact, it should be done.
Shalini, as you said, if she comes further delay the test, fetal handling would have taken and it will
Yes,
further reduce the thing.
exactly. So here
And
I'm
and
sure,
after
yeah,
wonderful
okay. So
point, ma'am.
let's go to the second slide.
I just wanted to clear 2 points. The
Yeah.
patient was the last in the clinic, so around 8:20 by this time only. So that's why I said that you do tomorrow morning, and because you're
Yeah.
doing the test in the morning, please do a fasting. I just
Fasting
wanted to
as well.
verify HbA1c.
Yes.
No,
And
you
yeah.
are
Yeah, I mean,
on
this
your
is
side,
real
you are
world. This is
perfect.
all real
Nimmi, you
world.
have done
So
fabulous
that's why
job.
we're talking real world and guidelines.
Yes,
Shalini, we should come to a practice that whenever the new pregnant lady comes, we should inform our staff to start with GTT. She might have been waiting for a long time already.
Yes, maybe.
By the time she visits the consultant, it would all got over.
But I'll
I
tell
want
you,
to-
another real world challenge would be without seeing the doctor, many
Yeah,
patients will not do a test.
Bhavtarni,
Not
the
do.
the
Yes.
patient
Will
may not
not do.
agree.
Patient
Patient
will
has
not
to
Okay,
come.
agree.
Yes.
okay,
Yeah,
okay.
they will not like to get a stigma that moment you enter in
Yes,
Bhavtarni's clinic and you get a oral
Test
GTT
done.
done. So
Okay.
they will say they are going to
Do it
everyone they are
tomorrow.
going to put that label, something like that.
Okay.
These are real world challenges that we face. That is why these
So
case discussions become so interesting.
Yes.
I also want to add one more thing, that Nimmi has done such a fabulous job, because most of the time we do not get such kind of case. Mostly they are diagnosed and they come to us. At
Yes.
diabetes clinic, they come after mostly diagnosis. So in my case, I would say my 95, 97%, 98% cases
Are
are
already
diagnosed
done,
already.
worked up.
So, but
Yes.
still, she asked for HbA1c fasting and post meal, OGTT. That's fabulous. So, it's
Yeah.
perfect.
Great. So
Yes.
next slide, Nimmi.
And this patient was very bad in pricking. She had so much of a
Yeah.
phobia also. And
Yes.
before coming to me with the OGTT test, she showed this to my friend who is a gynecologist in my area. And it was her who suggested कि doctor को बोलना दवाई चालू कर दे. So when I suggested insulin, she already had कि okay दवाई है जो हम ले सकते हैं. And more than that,
Nimmi, English, Nimmi.
oh,
English,
sorry.
please.
Sorry. So, the gynecologist is a very dear friend of mine, and before me seeing the report of OGTT, they actually went to her with the WhatsApp, and the doctor told the patient to tell me to start oral medicine. So I called my friend and I say that we can start at least basal insulin, considering the fasting is still,
Yes.
even in the
Yes.
SMBG's values are high. So
Yes.
she's insisted that let's start with metformin.
Yes.
That's why.
Can you just move to the next slide, please,
Yes,
Nimmi?
ma'am. I'll just do 1 second. Yeah. Okay. I have to minimize this. Yeah. So now, second slide is
See,
this
now
one.
here again, yeah. So this is where, metformin was started, a trial of MNT for 1 week was given, although, insulin should have been started there. But like, this is a real world case where, ideally, yes, insulin should have been started, but patients are not willing most of the time. So it's a tough job, bargaining and trying to convince them. Now look at the glucose readings. Definitely, I think the message is loud and clear. Fasting the target ideally should be 70 to 90, not exceeding 95 at any cost. And the 2-hour post meal value should be between 100 to 120. Look at the values here. So clearly this is a case where intensive management to be initiated, very importantly and rightly so, bargaining and starting a basal and then again increasing the doses. Show us the chart in the next one,
Yes.
Nimmi.
Yes. Yes, ma'am. Here.
Yeah. So comments from the experts on these glucose readings. This is a real world, so obviously patient is not doing, but I think this is where as physicians, it is our responsibility to have a conversation and tell the patient that in pregnancy, it is you cannot take a chance, because any exposure to hyperglycemia to the developing fetus can be detrimental, both for the mother and the fetus. So ideally, a 4-point SMBG, like Dr. Chawla said, ideally they say CGM or 7-point. But then 4-point SMBG, which means a daily fasting and a 2-hour post breakfast, lunch and dinner value should be done. But then this is what happens in the real world. So can we have comments from the experts on this?
I think Nimmi has done a very good job. most of the readings were under the value. Few were here and there, but it requires the patient's commitment as well as the diabetologist's commitment. Both have to be very committed to the frequent monitoring and adjusting the dose on daily basis depending on the blood sugar, on the diet and everything, so that the post meal remains below 120. Most of the time it is very difficult that you maintain it daily below 120, but most of the time it remains, the peak value remains below 120 and the fasting remains below 90. That will be a good control for your patient.
She has done
Shalini
it
has done a good
perfectly well.
job. Yes.
She has done perfectly well.
Yeah.
So
One more
what-
thing that I discover here. See, the need for basal insulin is also gradually going up.
Going up.
Yeah,
Again,
this is what
telling us
my
that
point
this
exactly,
patient,
that severe insulin resistance she is developing.
although
And-
she's lean, so this is a patient who
already-
already has some
and-
inherent dysglycemia in her.
And
So, you
also
know,
she's on metformin and still she required so
Yeah.
much of basal
so
insulin.
by
which is
16
quite-
weeks, see,
yeah.
by 16 weeks, she's added before lunch,
units.
before lunch fiasp, you know. And then
Yes.
by 20 weeks, I think 2 meals are, she's given her a bolus. So, you know, from I think 20th week to 28th week, we can see increase in Tresiba, which does happen as the baby grows. Insulin resistance keeps going up, so the insulin requirement also keeps going up. So again, this is one thing I feel that we should counsel all our patients on. Many times they say, how much dose should we increase? Every time I have to keep increasing because they're still scared. So I think the conversation that we need to have with our patients is very important, that insulin is safe, it does not cross placenta, and counseling the patient that as the pregnancy progresses, insulin resistance will increase and the demand for insulin will increase. So you need to increase the doses. So, and you know, this is as predicted, gradual increment in doses we can see. Any comments, or we can proceed further?
We can proceed. We can.
Okay.
Proceed.
Yes.
This
Yes,
is
Nimmi.
the carry forward of the same chart from 29th week. And now one change that happened in this patient was before 7th month, she was at her in-laws' place. So she was strictly following no carb diet. Now, after what we call a Shrimant here, she went to her parents' place, which was in a native small tier 3.
The baby shower, yeah.
Yeah, what we call baby shower. She went to from Ahmedabad to a tier 3 city town, and from there, her mom, the patient's mother, started feeding her more carbs and more dinner. So I had to add even before dinner dose after 32nd week, because when she was handling kitchen herself, she was making her own meals and she was off carbs, like off refined and carbs, complex carbs for majority of the time. So, but after baby shower, when she went to her mother's place and she had to eat what she was cooking, so her insulin levels started going up because of that in the dinner time. So this was
So
the
I want to say something here after seeing this chart, or what I can say, it more looks like a type 2 diabetes, or maybe she's turning out to be a LADA in future, because the insulin requirement is so much
Requirement is
high.
very
You can
high.
see here, in earlier time it was just barely like 160 and 170 of post OGTT values were there, but now the insulin requirement is 30 units of basal insulin and almost 30 units of bolus insulin. So even more than her weight, she requires the insulin, and it suggests that it might be turning out to be type 2 or LADA, or I don't know. We usually don't find true GDM or even early GDM cases requiring so much of insulin. Most of the cases they require low amount of insulin, so that could be a different kind of diabetes that we
No, Rutul, I differ here. I also am noticing this trend wherein, you know, towards the third trimester, especially the need for basal insulin goes up. And this is happening even in true GDMs, because post-delivery they revert to normoglycemia.
But not with that high amount of
Yes,
insulin, ma'am. Most of
yes,
the
yes.
cases, they require like
Actual true GDM where you're picking it up
they
in the
don't require
late
that
second
amount
or
of
third
basal
trimester,
insulin. Most
you
of
don't need so much insulin.
basal
First
insulin,
trimester you
especially
pick it
basal
up.
insulin.
Yeah, sir.
I
Yes,
think
sir.
Rutul has a point. There are 2-3 odd things in this patient,
Yes.
what I pointed out. One is there is no family history, no PCOS in the past. She's not obese.
Maybe type
So
1
she's lean, thin type. If at all she's lean, thin,
29
she's
years.
likely to be either LADA or lean, thin type 2. And
Yes.
sooner she will require
Yes.
insulin in her lifetime as a natural course, because she's neither typical you may say pre-existing type 2, although 5.7 is just very borderline. But the way her total requirement is almost coming out to be more than 1 unit per kg per day. I'm not sure how much is the weight, but she's already requiring close to 75 units along with metformin. I think metformin has been continued, and her
TDS.
requirement fasting is very, very high, that she's almost requiring 50% of her insulin therapy as basal
Basal
insulin.
insulin. This is what
So
That
she's not
Rutul,
typical,
Rutul,
she's
we
not
do have few
typical.
cases like this which have
Yeah.
turned to be LADA.
Yes.
So now what we are doing, we are seeing the C-peptide and following them further with C-peptide, seeing
Yeah.
that it is coming down.
Yeah.
So I think one
I
message
want to
that
make
appears
one more
here.
point.
Yes.
One more point, that in most of the cases, LADA or type 1, in case of stress condition, it may trigger. And pregnancy could be one of the trigger
Yes.
point where
Exactly.
it is getting like out.
Yes.
So
Yes,
that could
yes,
be the
yes.
case.
So I think a very important take home from here is, when you are seeing this kind of a presentation in your patient, be alert that this could be a potential LADA or a potential
Lean type
conversion
2,
to
yes.
early
Lean
onset type 2 DM,
Type.
because the
Right.
insulin dose, the behavior, how the patient's insulin demand is going up despite, the risk factors not being there. So I think that's another important point that we need to understand here. And of course, glucose values are very well managed, except for one odd fluctuations here and there. I think Nimmi did do a good job. So
Shalini, again, according to Dipsy, we would have found out well ahead, but still she has done it in
yes,
the very first trimester.
yes,
And see how this has progressed so
yes. See,
fine.
exactly, exactly. Yes, Nimmi, please move.
Nimmi, please proceed. Yeah.
Yes. Sorry. So these are the OB scans.
No, just go back to the earlier slide.
Sorry, ma'am. Yeah, this one?
No, after this.
This one.
No,
It's already
next.
done. Yeah.
Next, yeah.
Yeah. Now she's
Yes.
on the final slide.
Yeah, so this was her OB scans. I did not have this on my file, so I had to ask my ops friend. She had provided me with this scans. Her 28-week growth scan, the fetal weight is 1160 grams. AC is mild accelerated. AFI is 15 centimeters. Okay. Doppler's normal, and scan shows early signs of macrosomia because AC is mild elevated. 32 weeks, fetal weight is 2150 grams. Marked AC acceleration is same. Reduced HCAC ratio. AFI is increased to 17 centimeters. And at 36 weeks, her fetal weight was 2.9. AFI came down to 14 centimeters. She was cephalic presentation, placenta grade 1 and 2. And at 38 weeks, the induced labor was done. That was the gynecologist's choice. The ongoing dose at the time of admission to hospital was Tresiba 36 units, Fiasp 18 units before breakfast, 12 units before lunch, and 10 units before dinner, along with metformin, 500 milligram, 1 TDS. She delivered a healthy baby girl. A baby girl's weight was 3.2 kgs. There was no neonatal hypoglycemia. She was not admitted to NICU, and the baby girl was healthy. In hospital, day 1 after delivery, when I visited her, her fasting was 106 and ppbs is 129. Insulin, I had withdrawn after delivery itself. A patient was discharged after 3 days, and all the days her fasting was above 100, 105. So I decided to continue metformin 500 milligram once at night, and I advised to follow up after 3 weeks. This was not physical visit, this was a teleconsultation. Her husband was showing me the readings that they were monitoring in the chart in the hospital.
Metformin perfect
Sorry.
in the night.
Sorry, ma'am.
Metformin perfect in the night because her fasting is high.
It was all 3 days when they checked, the fasting was above 100, 105. So I told we can continue at least once at night.
Yeah, that's perfect. Perfect.
So again, that signal of
Nimmi,
macrosomia coming in tells us that, maybe
Primordial.
that slight macrosomic signal that appeared in the scans, in those 2 scans, tells us that, all
It
those gaps
suggests
that
that
we've
a
been talking about.
little less control. This is what it suggests.
Yes.
and one suggestion, Nimmi, in this case, although typically we say that first postpartum screening for with oral GTT ideally should be done at 6 weeks and 6 months.
Yeah.
But here this patient makes a case for a early screening as early as 3 days also.
Yes.
Ideally, she could have been screened at 3 days. What Dipsy also says, and we are also following in various studies, that if you do screening at 3 days before discharge or at discharge, you might be able to actually label this patient that if she has IGT or she has turned back to normal glycemia.
Right. And even we can ask her to continue monitoring at least alternate day or every third day regularly, so that we can come to know. And especially in such kind of case where insulin requirements were high, she may continue to monitor.
Then 6 weeks screening and 6 months screening for with oral GTT.
Postpartum.
Yes. Dr. Pratap, you were saying something.
No. I was just looking at Nimmi. Is there any further follow-up of this patient?
She is a continuing patient.
Yes.
Next, do we have something beyond this?
Yes. I have to minimize this slide. 1 second. Yeah. This is the postpartum follow-up. She was still at her native place for 3 months. So there she was doing her SMBG, fasting was 90-100 with metformin once, and only after lunch she was doing, not after breakfast or dinner. 2 hours after lunch it was coming below 140. 3 weeks postpartum, because I told her husband ki do fasting PP2BS and come with the lab reports. So her husband alone came to me with her lab reports from her native place, where fasting was 96, PPBS is 126. So I decided to discontinue the metformin even 500 milligram once a day, but I advised her to continue low carb diet, and I talked with the patient on phone. After 3 months, when she came back to her house here in Ahmedabad, she came with the lab workup, and the fasting was 92, PP2BS was 158, and I had advised another HbA1c on the last consultation. So she did HbA1c, which was 5.2, 5.3. So I advised her that you can be pre-diabetic in long run. So better to continue low carb, high protein, high fiber diet and reduced fat.
But this lab was absolutely normal. No reason that we should label her as pre-diabetic here.
Yeah, this is
now
normal 92 and
within 1 year.
128 and HbA1c 5.3.
See, this is 3 months. This is 3 months after delivery, everything has normalized.
Yeah,
But 1 year she has become pre-diabetic.
Yeah, pre-diabetic, I agree. But again, this is a little unusual. What we were contemplating, that her insulin requirement was very high, close to 80 units. 50% of that was being given basal. But at 3 months, she has come out to be normal. That means she doesn't have pre-diabetes at all at 3 months. So that means everything happened while she turned into GDM. So again, another story, what Dr. Shalini was also saying, that many GDM patients these days, they are requiring very high dose of basal insulin to maintain euglycemia. And moment she has terminated her pregnancy and delivered, she has at 3 months turned out to be normal glycemia. Although at 1 year, you may say she's borderline pre-diabetic.
This may be because of the very good insulin dose what they followed during pregnancy. She had a very good honeymoon period.
Yeah. Agreed.
But it reverted later as pre-diabetes.
At
This
1
is
year.
very common
At 1
case.
year. 1 year, yeah.
Yes.
So may I ask one question, Dr. Nimmi?
Yes, sir.
What was her gestational weight gain total? And what
Wait,
happened to her weight over a period of next 3 months and 1 year?
At 1
okay,
year is very
okay,
important.
Very
okay.
important.
She was actually 53 kgs when she conceived, and at the last visit when she came to me on 7th month, I did not see her after that. Her weight gain was 6 kgs till that.
Not
After that,
much.
I consulted her on phone. Not much
Hmm.
weight gain also.
Oh, yeah.
So
6
still
Post,
kgs
quite
is it?
but
surprising
postpartum,
because our total weight gain at third trimester was around 60
7
kg.
kg, 6
No, no, no,
kg.
So
no, no,
and
no. She's
and
saying till 7th month it was
Till
7.
7th
Month
month,
it
Then
was.
8th and 9th month she would
She
have
was not here.
definitely gained weight.
gained
so
weight.
ma'am, maybe
So we don't
10
have
10
that
kg or
I don't
11
documentation
have
here.
it.
kg. So her total weight gain and total weight at third trimester could be around 60, 65 kg, and in some
Even
Maximum
then,
cases it
it
60.
is
was
Hmm.
normal because
75.
you may gain up to 7 to 10 kg during
Yes,
pregnancy.
7 to
up to
10.
12 we can.
7 to
But
11 is
Yes.
the
postpartum,
AMA guideline.
She at third, I did not have the initial data because she was not here. But at 3 months when she came for follow-up, she was 56 kgs.
fine,
Again,
it's
okay.
good.
That I
Fine.
had. So I had the
Good.
data that till she visited me, and when she visited me, when she was in native place, I could not record her weight at that time.
And she was not
Shalini,
having
this type of case,
any features of insulin resistance like
No, sir,
acanthosis
no
nigricans or
acanthosis, no
nothing.
dark
No,
spots
no,
on the
no,
body, no acanthosis, nothing,
no, no.
nothing.
Right.
sir,
But
as Rutul said, nowadays they get married late, further delay the children, and the age of occurrence of diabetes coming down all coincides, and we have plenty of cases like this only, all starting in the first trimester.
Right.
no, this was one unique case for me because generally when I see GDM, I see them in 24, 26 weeks. So mostly I don't need to give so much of insulin.
She's
It's
the
only
So
first
now the
trimester.
placebo that
concept
I give.
of so Nimi,
Yeah.
even you can change your nomenclature. You can write this diagnosis as not early onset, but you can
Okay.
write directly early GDM.
Early
So
Yes.
we
GDM.
call it eGDM. Now it is already established nomenclature. So this is very common thing nowadays.
And with HbA1c 5.7
I
is too
think this case is a very good case. One is the very unusual presentation of maybe LADA or maybe very, very early, you may say, pre-existing disease, which at 3 months it is proven that it was not there. At 3 months, she is absolutely normal, having a normal glycemia. Even at 1 year, she has mild degree of fasting hyperglycemia, 108. Postprandial is still less than 140, and HbA1c is just 5.8, maybe because of 108 fasting only. So she is still almost like a euglycemic patient at 1 year. So in this patient, we did first postpartum follow-up at 3 months and then maybe at 1 year. But I think that again teaches us that we wrote one editorial in IJGDC with Dr. Hema talking of index pregnancy as a window of opportunity to intervene. And we talked of a fourth trimester concept of screening. That means first, second, and third trimester during pregnancy, and the fourth trimester ideally should be postpartum. That you should do a screening at 3 days ideally, and then at 6 weeks, and then at 6 months, so that you don't miss that opportunity of getting this follow-up, which was rightly done in this patient, although you didn't do it in on third day, but 3 months and 1 year has shown that she still continues to be almost like euglycemic. And while she was pregnant, she developed early GDM, clearly a diagnosis of early GDM, and her requirement of insulin was very, very high, which is also very unusual in GDM. So she
We
is
do,
more like
we,
insulopenic, and if at all she goes into over the years, maybe next 5 years, going to develop GDM, going to develop diabetes, I'm sure she will develop something like LADA or maybe very lean type 2 diabetes because she
yes.
has no classical symptoms of type 2 diabetes.
Another thing, sir, I want to highlight is I salute to Dr. Nimmi's obstetrician that she chose to have normal vaginal delivery. Otherwise, in such an higher insulin requirement, most of
Usually,
the obstetricians they
Usually.
choose to have
That is
cesarean
true, but
section in
nowhere
these
we
cases.
have mentioned anywhere. No
Yes,
guidelines, no evidence
yes,
tells you
yes.
that if
So
requirement
yeah,
is high,
yes,
you
yeah,
must
in the
have a
requirement
Caesars.
is high,
Yes.
even type 1 diabetes or
Yeah, yeah, they can take
yes,
even
that is the
LADA or
common
type 2
practice.
diabetes, any kind of diabetes
Unfortunately,
with
yes.
pregnancy it is not an indication to
It is not an
cesarean section.
So I
It
think
should
an
unfortunately
it should be
important
treated.
message here is again that yes, diabetes per se is not an indication for a cesarean
indication for
section. So I think a lot of factors go into deciding. Our OBG friends would agree. They don't want to take a risk, and that is why usually they prefer doing an LSES, a planned LSES. But then ideally, if everything is progressing normally, a trial of normal labor should be given. We have some audience comments also coming in. Dr.
So
Ajay
yeah,
Gupta,
Yes.
yeah,
uh, who
yeah.
Ma'am,
says
So
that
yes,
yes.
Ninad,
yes, sir. Ajay
Ninad was
Gupta
saying
sir
something.
has, yes, Dr. Ajay Gupta
Yes.
has raised a really nice thing. He said GDM is a major risk factor for developing permanent type 2 diabetes. The postpartum OGTT will categorize the outcome into one of three parts. Normal glucose tolerance, diabetes has resolved. However, the lifetime risk remains high. Pre-diabetes, impaired glucose tolerance or impaired fasting glucose indicates persistent metabolic issues requiring lifestyle interventions and possibly continued metformin, and over type 2 diabetes requiring immediate and formal diabetes management. This was said by Dr. Ajay Gupta, sir. There is another question by Shivani Gupta as well. Is metformin safe in all three trimesters?
So yes, controversy of decade or not decade century, still it continues. So yes, now most of the guidelines they recommend, they suggest that in such cases definitely metformin can be continued as it was started earlier, and usually we try to start metformin after 20 weeks as per Indian guidelines after 20 weeks, but it is okay to start early if we don't want to start basal bolus therapy with metformin. What Nimmi started was that degludec insulin soon after metformin, so definitely it can be started. Most of the guidelines they suggest that it is safe and it can be started at any point of time during pregnancy nowadays.
Rutul,
Only thing is you
UK
should be
guidelines, it
clear.
has clearly said
Yes.
that from conception
Yes,
to
nice
delivery
guidelines.
can be very well.
Nice guidelines, India DCGI, everybody has
Yes,
approved metformin.
yes,
But one
yes,
thing we should understand is where it should not be used.
yes,
So ideally,
exactly.
if you are seeing a risk of prematurity, preterm, or if you are seeing IUGR small for gestational age, if you are seeing umbilical
Pre-eclampsia,
artery restriction, if you are seeing reduction in the intrauterine arterial flow, so those kind of
pre-eclampsia,
hypoxic situations,
pre-eclampsia,
metformin should be
pre-eclampsia.
stopped. Preeclampsia coming in, those kind of places, metformin should be stopped. If you are suddenly seeing the mother is starting to lose weight during pregnancy, if she's on metformin and she starts losing weight rather than gaining weight, which should be the normal trajectory in pregnancy. So, a fetal undergrowth, IUGR, SGA, preeclampsia, so reduction in uterine flow, uterine arterial flow. So, those are the contraindications where metformin should be stopped. Otherwise, it is considered safe in pregnancy and can be a good choice, especially in milder degrees of dysglycemia. Or if the patient is not willing for insulin, you can give her a trial of metformin. But if there is frank dysglycemia, obviously insulin needs to be initiated.
Ma'am, I have a
Rina, there's
follow-up
another
question to
question. Can
this.
you take that
Ma'am,
up,
I
please?
have a follow-up question to this as well.
Yes.
If the patient is already taking, let's say, metformin and unwilling, let's say it's in the third trimester, and the patient is very well controlled with metformin, all the other parameters are normal, but the patient has a high carb diet and only has single value, let's say post-dinner patient is having hyperglycemia. Can we add an AGI like acarbose?
There are no data for AGI, though
It's
very
AGA,
It's
of
small
not
course,
numbers.
approved yet.
better
Dr.
insulin, better
Bhavkari
insulin.
only has few
Yeah, I
patients
have used a
in
lot,
her study, but
sir,
it is
but
not
I have
approved
used
yet.
only with insulin, not
Nimmi,
alone.
can you stop sharing your slides so that we can have all the panelists on the
I'll
screen?
I'll stop.
Yeah. So we can
Actually,
have
we
all
have
panelists on the screen.
Acarbose was used only with insulin to reduce the dose of insulin, not alone. Here, better to start with insulin if the postprandial in the night is very high.
Yeah,
Being a
single dose
precious
of
insulin.
prandial insulin can be given at
Yes.
along
And
with
as acarbose is not absorbed in systemic circulation, so we definitely can consider, but I feel that it is not in guidelines, so it is off
There are
label.
no,
You can use
you
it.
may
there
use,
are
but
no
it is still
data.
not approved.
Yes, we don't have
There are no
sufficient
data.
data to support that.
And I think it is not going to happen also, because none of the companies or none of the ethical committees are going to give go ahead
approval.
with use of oral drugs which are lacking data. So that is going to be a difficult job.
Yeah,
And there are
no study
multiple
yet,
problems
no
with
study yet
acarbose as well.
on use of acarbose.
Yeah.
One question to all the panelists and to Dr. Nimmi, whether this patient should be considered also at high CV risk, whether there was any family history of cardiac disease or hypertension or other problems, and whether this patient should be screened for cardiovascular other risk factors, not only sugar, but lipids and other things, whether it should be screened in this patient or not. So to you as well as to all the panelists.
I don't think she's a young patient. She's a young patient, still less than 30 years old. There's no cardiovascular risk in this patient. She's not obese. There is no family history of diabetes. Even if she has had PCOD, we could have said PCOD is also a greater CVD risk, except that she had GDM, which of course is part of continuum of CVD risk. But I don't think it warrants a cardiovascular screening at this age at all.
Sir, can I ask one question? If, for example, this patient is going to be a patient because she's very willing to not progress to diabetes, that's what she has conveyed. So next time when she comes, I was planning to order her for C-peptide, HOMA IR, and fasting insulin. So can I add other ACVD parameters also? Can I add lipid profile?
Nimmi, don't want to HOMA IR, all that. You just do C-peptide with the lipid profile, all that.
Okay.
I don't think it is part of any protocol that you get all these things done. At the most, she's IFG with single value of 102 or 104 or 106. So you may follow her in terms of conversion to type 2 diabetes. Lifestyle modification has to be emphasized again and again. Best will be if we can prevent conversion to type 2 diabetes or lean type 2 diabetes in this patient. But I don't think she requires or there is a mandate for a atherosclerotic cardiovascular disease based screening for this patient at age of 30 because she has no risk factor as such.
Nimmi, it is very interesting to note that C-peptide are high in lot of cases because even if they are lean also they are sedentary. So see to the C-peptide. That is very interesting.
Lean insulin resistant diabetes.
Yeah. Yes.
But still, I would say that lipid profile where triglyceride could be helpful in finding so many things. So, like maybe we are thinking on the
But she's a breastfeeding mother. She's a breastfeeding mother.
We don't want it for treatment, but we just want to screen it for many other things. Yeah.
I think the discussion can go on, but I think we've come to the end. So, Ninad, maybe you can, before you thank everyone, I would like our experts to give us maybe some take-home messages, Dr. Pratap, Dr. Rutul, and we can, before we close, and then Dr. Chawla, maybe you can give us a final take-home. Just brief take-homes before we wind up.
Yes. Pratap, sir?
Yes. So I think an excellent case by Dr. Nimmi and excellent discussion by all the panelists. So this is an eye-opener case. So any patient presenting first time in the clinic with pregnancy should undergo oral glucose tolerance test. 75 gram, give them glucose and check sugar after 2 hours. And that will give you a very good clue about her overall metabolic profile, whether she is glucose compliant or glucose insulin resistance, glucose intolerance, whatever it is. So that way you can pick up case at an early stage, you can give them a proper treatment, and you can try to avoid the harmful implications of hyperglycemia on the baby particularly the macrosomia and the long-term risk. And Dr. Nimmi has done an excellent job. Be proactive in monitoring, in starting drugs, in starting insulin. Don't wait too long. You have to be very, very much proactive as far as glucose control in pregnancy is concerned.
So, should I add
Yes,
something?
yes, please, Rutul.
Sir has almost summed up everything. But for me, the most important thing after diagnosis is the monitoring. Monitoring is the key in any case in gestational diabetes. If you want to go for like good management, you should have thorough monitoring at least 4 times a day, that is fasting, post breakfast, post lunch, post dinner, and even pre meal if it is required, or if it is not controlled after giving insulin multiple shots. If it is not controlled, then you may even check pre meal sugars as well. Add CGM to those cases where it is feasible, and it gives so much of data to us. And also intermittently use CGM if it is not possible continuously using it. After that, the most important thing comes is postpartum follow-up and postpartum OGTT at 6 weeks, 6 months, or if you suspect like case of type 2 diabetes or early type 2 diabetes, then you may continue monitoring and for even just after postpartum.
Dr. Chawla, your comments, please.
I think very rightly summed up that this case is sort of not very unusual, but an eye opener in three aspects. One is that EGI today is a established norm. We have been talking of early glucose intolerance, and early GDM today is a known entity, and this case is classically Indian phenotypic presentation of early GDM manifesting at 12 or 14 weeks with a very unusual family history. Negative for that, she's a lean, thin, typical Asian phenotype developing early GDM without much of risk factor, no obesity, no family history, and no PCOD. And she's, although 29, that is the only risk factor which you may say that leads to maybe little greater risk for developing early GDM in this. Management-wise, case has been managed in an excellent way. I must congratulate Dr. Nimmi. Excellent euglycemia has been maintained, barring few values more than 130. Most of the sugars are normal, and most of the time she has been the patient has been doing at least 4 values a day, which is commendable. And very good thing that she started with metformin in right on visit 1 when she was not willing for insulin, and immediately a basal insulin was added, seeing her fasting sugars, which was very rightly done. And whenever she realized that she required 1, 2, or 3 doses of boluses, it was accordingly managed. And I'm sure if you see the overall maybe estimated HbA1c in this patient, it must not be more than 5.8 during the pregnancy. So it has been a wonderful control. They have screened in the postpartum period also, first time at 3 months and at 1 year, and she still continues to be fasting, you may say impaired fasting hyperglycemia, although she has not yet converted to type 2 diabetes. So all lifestyle modification and efforts have to continue in terms of preventing conversion to maybe lean type 2 diabetes in the future. And overall, I think it is a very good case, and it has been done very, very nicely and meticulously.
Thank you so much, sir. Yes, thank you so much, sir. Thank you so much, ma'am. Thank you, Usha ma'am. Thank you, Shalini ma'am, Rutul sir, Rajiv sir, Pratap sir.
One request, requesting everybody to do the single test procedure for all the pregnant women at the earliest. Before
first visit possible.
Before the fetal handling starts, it's a must. And I am seeing the C-peptide even for the adolescent unmarried girls being very high. Majority having 6+. So please follow up because pre-GDM is very common.
Yeah. So it has been a wonderful beginning of PregaClinics, and I am sure it is just the beginning. And as it grows over year after year, we will definitely be seeing very, very unusual cases of GDM in this webinar.
So,
Best of luck to
yeah.
Congrats,
to
Shalini.
So I would like to
Congratulations.
deliver this vote of thanks to everyone who's joined today, all our faculties, starting with our senior mentor, Dr. Rajiv Chawla, our experts today, Dr. Pratap Jethwani and Dr. Rutul, our moderator, Dr. Ninad, and of course, our speaker, Dr. Nimmi, and Dr. Bhavtarini ma'am, who's joined us today. So thank you very much, and all the delegates, the active participation and the questions that we've gotten. So a big word of thanks to all the people who've joined today. And I promise that PregaClinics, with its motto of every pregnancy deserves precision care. This is very, very important, I think. So every pregnancy we need to manage very well, and different aspects of pregnancy we'll be covering in our future episodes of PregaClinics. So PregaClinics, please watch out. Every second Wednesday of every month, 8 to 9 p.m., we will come to you with real world cases. And for all the people who are logged in, if you want to discuss any of your real world cases, please feel free to message me. And we will definitely welcome you on board to present any interesting cases that you may have on hyperglycemia in pregnancy, right from gestational diabetes to pre-gestational to early DIP. So any case that you would want us to highlight, please feel free to reach out to us, and we will definitely have you as our presenters and as experts joining us in the future episodes. So thank you very much, all the faculties, all the delegates, and of course, Team USV for their support in this first episode of PregaClinics. And we look forward to all of you joining us in the second episode in January, on the second Wednesday of January from 8 to 9 p.m. Thank you so much, everyone.